all patients are different. Lung cancer is a very heterogeneous disease. There's smokers, non-smokers, former smokers, patients exposed to toxic pollutants, radon gas, genetic elements. So every tumor has a different driver. Think of it as the car, and you got to figure out what's wrong with the car. And if we want to keep that broken car from moving, we have to figure out what's the key part of the engine that we can destroy. We don't want to take out the radio, right? Because the car will still go. And that's why it's very important to use biomarkers to understand what is that engine for each tumor. The challenge is it's not as simple as we would hope, of course not. We're not going to, in my opinion, find 20 more drivers, meaning 20 more genes where we have one drug that it might work. We're reaching the point where the complexity, in my opinion, has gotten to the point where we're going to need combinations. We're going to need a combination of an immunotherapy and a targeted therapy, or a combination of two targeted therapies to hit two pathways, because when you block one, another one goes up. And these things do get challenging because these drugs are not without the side effects, at least the oral small molecule tyrosine kinase inhibitors. The antibodies tend to be a little bit more specific. I'm very excited about what's called armed antibodies. By that I mean you identify your address or some antigen, something that's specific to the tumor, or at least highlighted in the tumor versus a normal cell, and then you deliver an antibody with a payload that's going to be toxic to that cell. So all of these are new approaches that are being looked at right now, but it all starts and hinges on understanding the biology of the tumor and the biomarkers so that we can target it more specifically.